Good morning. I'm Dr. Ruwangi Dissanayake, Senior Lecturer from the Department of Pediatrics, Faculty of Medicine, University of Colombo, and Honorary Consultant Pediatrician at Lady Ridgeway Hospital. Today I will be talking to you on the topic of hematopoietic stem cell transplantation, a cure for Sri Lankan children with transfusion-dependent thalassemia. During my presentation, I will be discussing briefly about transfusion-dependent thalassemia in view of preparation of a child for a successful hematopoietic stem cell transplantation. Then I will move on to the topic of hematopoietic stem cell transplantation per se. What hematopoietic stem cell transplantation is, different types of hematopoietic stem cell transplantation that is available in Sri Lanka for children with transfusion dependent thalassemia, and important steps in the management of these patients in view of optimizing post-transplant care. So let's start by looking at transfusion-dependent thalassemia. A transfusion-dependent thalassemia is a thalassemia which requires regular blood transfusions for survival. Examples for transfusion-dependent thalassemia are beta thalassemia major and severe HBE beta thalassemia. During 10 years of experience in Sri Lanka of transplanting children with transfusion-dependent thalassemia, the majority of our patients have been patients with beta thalassemia major and a few with severe HBE beta thalassemia. If we look at the Sri Lankan situation, the burden of disease, according to the research and surveys which have been conducted, around 2,000 patients with transfusion-dependent thalassemia are in Sri Lanka, and to provide care for these children and adults, it costs about 5% of the recurrent health budget. About 45 to 55 newborns are born annually with transfusion-dependent thalassemia. Unfortunately, the mean age of survival of these patients is quite low, which can be as low as 13 years of age with a range of 2 to 44 years. Patients with transfusion-dependent thalassemia usually present before 2 years of age. The presentation generally varies from about 6 months of age to 2 years of age. They will present with symptoms and signs of anemia, such as poor feeding, failure to strive, and if the anemia is severe, the parents themselves will complain that the child is pale. And they also can complain that there is abdominal distension because these children have hepatosplenomegaly. When a child presents with clinical features compatible with a transfusion-dependent thalassemia, we will go ahead and initially do a full blood count as well as a blood picture. The hypochromic microcytic picture with target cells will further support the diagnosis of a hemoglobinopathy. And then we will go ahead and confirm the diagnosis with high-performance liquid chromatography. These patients will have very high levels of HbF and low levels or absent levels of HbA. If the parents request and can afford genetic testing, then it can be offered to confirm the specific mutation. Once we have confirmed the diagnosis of beta thalassemia major or a transfusion-dependent thalassemia, knowing that these patients will have to be on regular blood transfusions, it's extremely important to send blood for extended phenotyping. Also, The family screening with HPLC is important. Having identified carriers in the family, it is very important to counsel them about the autosomal recessive nature of inheritance and the future risks to offspring. Once we have initiated the blood transfusions, the transfusions will have to be given regularly, which can vary from 2 to 5 weeks. What is important is to maintain a pre-transfusion hemoglobin of 9.5 to 10.5 grams per deciliter and a post-transfusion hemoglobin of 13 to 15 grams per deciliter. If this sort of a transfusion regime with leukodepleted packed red blood cells is maintained, the quality of life is improved and other problems like hepatosplenomegaly due to extramedullary hematopoiesis will be suppressed. And when you examine these patients, there will actually be no hepatosplenomegaly. The absence of hepatosplenomegaly is important for the transplant process. While this patient is on regular blood transfusions, they will invariably develop iron overload, and it is important to initiate chelation at the appropriate time. Serum ferritin is recommended after the 10th blood transfusion, and if more than 1000 micrograms per liter, according to the age of the patient, chelation is started. Oral deferricerox is now the more popular iron chelator, recommended after 2 years of age. It should be given on an empty stomach first thing in the morning, and the dose has to be optimized to a maximum of 40 milligrams per kg per day. Subcutaneous desferrioxamine is also time proven good chelator. It has to be given desferrioxamine has to be given subcutaneously over a period of about 10 to 12 hours. Oral deferriprone is another oral chelator which is given after 6 years of age. Now, a patient with transfusion-dependent thalassemia who is on regular blood transfusions is being chelated with proper monitoring of iron overload still can develop endocrine complications. So the endocrine follow-up is extremely important. Usually the endocrine complications develop after 5 years of age. However, if the child is iron overloaded, it can happen even before. Some of the endocrine complications that are commonly seen in patients with transfusion-dependent thalassemia are short stature, diabetes mellitus, delayed puberty, hypothyroidism, hypoparathyroidism, low bone mineral density, and osteoporosis. Appropriate investigations as well as necessary treatment needs to be started at the correct time. Since these patients are on regular blood transfusions, though the risk is now minimum, they still do need infection screening, for example, annual screening for the possibility of hepatitis B as well as hepatitis C. It is recommended that the follow-up for iron overload is done with serum ferritin 3 monthly in the absence of infection. It is best to maintain a serum ferritin of less than 1000, as this will also affect the outcome of hematopoietic stem cell transplantation. Once it is decided to have a hematopoietic stem cell transplantation, rapid drop of serum ferritin by treating will not be that helpful. It is the chelation history which is important. We also have the facility to do T2 star MRI of the liver and the heart after 7 years of age in children with transfusion-dependent thalassemia. This will also help in deciding and optimizing chelation. This image shows a T2 star MRI of the heart. Here, the box with the green values are the patient's values, and the different color coding at the bottom are the normal ranges. And if you look at this, the T2 star R2 and the myocardial iron concentration is within normal limits in this patient. Now let's move on to hematopoietic stem cell transplantation. Let's start by looking at what hematopoietic stem cell transplantation is. So it is a treatment modality. It is a therapeutic procedure. It is available as a cure for transfusion dependent thalassemia, and also in certain conditions, for example like multiple myeloma, it might not cure but prolong the life. So hematopoietic stem cell transplantation is a therapeutic procedure which will cure or prolong life in a broad range of hematological conditions which are malignant or non-malignant. During this procedure, healthy stem cells are infused into the patient who has a dysfunctional or a depleted bone marrow through a central venous line. This slide shows how hematopoietic stem cells which are taken from the bone marrow, which become multipotent stem cells and then lead to lymphoid progenitor cells giving rise to NK cells, T cells and B lymphocytes, and also those of the myeloid lineage giving rise to neutrophils, platelets and red cells. During the procedure of hematopoietic stem cell transplant, the patients or the recipients' diseased bone marrow as well as the immune system is destroyed with conditioning. I will take you through what is conditioning again later. And this conditioning consists of high dose chemotherapy with or without radiotherapy. For the transplants that we are performing in Sri Lanka, we don't use radiotherapy, but we do use high dose chemotherapy in preparation to accepting the donor stem cells. Healthy hematopoietic stem cells will be infused via a central venous line into the recipient after the conditioning. Now, what are the sources of stem cells which you use for the hematopoietic stem cell transplantation? There are three possible sources. One is bone marrow, the other is mobilized peripheral blood stem cells, and the third option is umbilical cord blood. This slide shows stem cells being taken from bone marrow. So these stem cells can be obtained either from the patient itself, like that happens in certain malignancies like multiple myeloma, or it can be from a different suitable donor. So when it is the recipient himself or herself who is also the donor, it is called an autologous transplant. When it is another healthy donor, it is called an allogenic transplant. All transplants that are done for patients with transfusion dependent thalassemia are allogenic hematopoietic stem cell transplants. Currently, for a lot of hematolymphoid system disorders, allogenic hematopoietic stem cell transplants are the only available cure. And in Sri Lanka, for patients with transfusion dependent thalassemia, aplastic anemia and chemorefractory leukemia and lymphoma, also the only as well as immunodeficiencies, the only available cure is hematopoietic stem cell transplantation. There are different types of donors who are suitable for this sort of allogenic transplant. It's called a syngeneic donor when an identical twin is available, which is extremely rare. And the next best option is a HLA matched sibling. And if there is a HLA matched sibling, then that would be the ideal situation. Most of our transplants in Sri Lanka have been from HLA matched siblings. However, considering the small family size, only about 25% of families will have such a donor. I would like to point out at this point that we should never counsel a family with a child with transfusion dependent thalassemia to go ahead and have another child in order to perform a hematopoietic stem cell transplantation, knowing that because of the autosomal recessive nature of the condition, there is a risk that even the other child, the next child, can be affected by a transfusion dependent thalassemia. Moving back to donors, in the absence of a HLA matched sibling, then an unrelated donor, a matched unrelated donor is the next best option. In the absence of all this, a partially matched haploidentical donor is also available for hematopoietic stem cell transplantation. Moving back to conditioning, so this is the preparative regimen that is administered to the patient who undergoes hematopoietic stem cell transplantation before stem cells are infused to the patient. It will cause myelodepletion targeting the host stem cells as well as lymphodepletion targeting the host lymphoid cells. Now, once the patient undergoes stem cell infusion as a result of the conditioning, all counts will drop and there will be a stage where this child becomes pancytopenic, and then slowly the counts are supposed to increase. We know that there is hematological recovery, engraftment, initial success of the transplant when the neutrophil count is 500 or more on 3 consecutive days and the platelet count is 20,000 or more without a platelet transfusion during the preceding 1 week. If we look at the history of hematopoietic stem cell transplantation in the world, Dr. E. Donald Thomas, an American physician, is known as the father of hematopoietic stem cell transplantation for performing the first successful hematopoietic stem cell transplantation. If we look at the history of hematopoietic stem cell transplantation in Sri Lanka, the first allogenic hematopoietic stem cell transplantation was performed at the Asiri Central Hospital 10 years back in 2014. This was headed by Professor Lalindra Gunaratna, Professor in Pathology and Consultant Hematologist from the Faculty of Medicine, University of Colombo. I was the consultant pediatrician for the program, and there were other academics from the Faculty of Medicine, University of Colombo also initiating this, and we have a lot of consultants from Lady Ridgeway Hospital as well as other hospitals who help us with this program. Facilities to carry out successful transplants including flow cytometry, molecular genetic laboratory, facility to do cyclosporine and tacrolimus levels, a facility for irradiated blood products, and rooms with positive pressure and hepatofiltration were all available. To help us start the transplants, a non-profit making foundation, Cure to Children Foundation, headed by Dr. Lawrence Faulkner, came along to Sri Lanka to train medical and other nursing professionals. And thalassemia support group, Lanka Thalassemia Circle, also helped us find suitable patients to start the initial transplant process. I would encourage you to read the Ceylon Medical Journal, where we have described the first hematopoietic stem cell transplantation for transfusion dependent thalassemia in Sri Lanka in 2014. And our first 4 transplants for transfusion-dependent thalassemia was presented at the annual academic sessions of the Sri Lanka College of Pediatricians in 2015. It was also awarded the prize for the best oral presentation. We also proceeded to do matched unrelated donor transplants for transfusion-dependent thalassemia. These are done for patients who are suitable for a transplant, however, don't have a matched sibling. In the absence of a matched sibling, we get down stem cells from donor registers like the Datri, India, and perform transplants for these patients. The first few transplants, the matched unrelated donor transplants that we performed, had a good outcome which was similar to international centers of excellence. And the outcome of the first 5 patients was presented at the annual academic sessions of the Sri Lanka College of Pediatricians and the Asia Pacific Bone Marrow Transplant Congress in 2017. Having performed these transplants, our center at Asiri Central Hospital was approved as the Postgraduate Institute of Medicine approved center for hematology trainees in transplant, and Sri Lanka was officially accepted by the Asia Pacific region as a country performing hematopoietic stem cell transplantation. Moving on to complications seen after hematopoietic stem cell transplantation. I told you that we eagerly await to see the neutrophils, the platelets picking up and the hemoglobin rising and then becoming gradually transfusion independent. However, some of these patients can have graft failure, a dreaded complication. This can be primary or secondary. I will be taking you through what is primary graft failure as well as what is secondary graft failure. Then there can be other complications such as graft versus host disease, which also can have detrimental effects, even resulting in mortality in patients with transfusion-dependent thalassemia. There is also veno-occlusive disease as well as a multitude of infections which can happen in these patients. What is primary graft failure? When the absolute neutrophil count is less than 500 and is associated with pancytopenia even by day plus 30, then we call it a primary graft failure. The date that the transplant was performed is considered day 0, and after 30 days from that, if there is no evidence of engraftment, then we know that there is primary graft failure. The outcome can vary if there is primary graft failure. The best would be that the patient's own stem cells come up and then the pancytopenia settles and they recover. However, they will be back to being transfusion dependent. Unfortunately, some of them can remain aplastic, and unless a second transplant is done, then there can be mortality. Secondary graft failure is the engraftment has occurred but subsequently there is rejection. So there is a decline in the hematopoietic function, which is manifested as a dropping of the hemoglobin, the platelets, the neutrophils. It can be a combination of one of those, and these patients will then require blood transfusions, which need to be always at the beginning irradiated, as well as other growth factors such as granulocyte colony stimulating factor eventually. Graft versus host disease is also a main complication which can have detrimental effects for patients with transfusion dependent thalassemia following hematopoietic stem cell transplantation. The reason for graft versus host disease is the immune response against tissue antigens of the recipient because of donor T cells. It can be either acute or chronic. The classification is now changing. Earlier, it was clearly during the first 100 days acute graft versus host disease, and afterwards it's chronic graft versus host disease. There are three main systems which are involved. One is the skin, where there is a generalized erythematous maculopapular rash, sometimes in the severe forms where there is even bullous formation, which is itchy. Evidence of the gastrointestinal system is with a profuse watery diarrhea. There can also be vomiting, and then liver involvement with elevation of the bilirubin values. This picture shows GVHD of the skin. Graft versus host disease is routinely treated with steroids. In some patients it is steroid resistant, and in steroid resistant patients the outcome can be poor. Sinusoidal obstruction syndrome or veno-occlusive disease is also another complication which occurs post-transplant. We know that, or we clinically suspect, the presence of VOD when the patient develops jaundice, there is hepatomegaly with tenderness, increase in weight gain, fluid retention, ascites, and refractory platelets. These patients are managed with fluid restriction, furosemide, and hopefully recover. Sometimes can result in mortality. Because of the immunosuppression, these patients are prone to multiple infections. Infections are also a main cause of mortality in patients following transplant. Viral infections such as cytomegalovirus, Epstein-Barr virus, adenovirus, as well as HSV are common in these patients. Cytomegalovirus, if symptomatic, can be a cause for mortality, and monitoring of CMV and preemptive treatment is done to prevent mortality. Gram-negative and gram-positive organisms as well as encapsulated organisms can cause different infections in these patients. Invasive fungal infections such as Candida and Aspergillus are also seen post-hematopoietic stem cell transplantation. During and after the transplant, to prevent GVHD, patients are on immunosuppressants such as cyclosporin, tacrolimus, MMF. These immunosuppressants are continued for a variable period of time depending on the outcome of the patient. If uncomplicated, it is usually tailed off by about 1 year of age. Patients with graft versus host disease may be on immunosuppressants for longer period. However, the good thing about these transplants, unlike a patient who has had a solid organ transplant, is that if the transplant is successful, they will be off medications by about 1 year, 2 year post-transplant, transfusion independent, with almost a nearly normal life. Because of the risk of infections prophylactically, they will be on antiviral and antifungal medications as well as cotrimoxazole. It is very important to provide a proper nutrition to these patients. A healthy, balanced diet which is cooked at home is what is recommended. Endocrine follow-up with these patients is extremely important. It is for two reasons. The thalassemia per se, like I highlighted earlier, will cause endocrine complications. The chemotherapy which is used also can cause other problems. Therefore, regular endocrine follow-up is needed for them. After about 1 year post-transplant, we also investigate them mainly with a serum ferritin to look for evidence of iron overload. And if the serum ferritin is high, once again we start them on iron chelation. Sometimes if the hemoglobin is on the lower side, then the management of the iron overload is with venesection. If not, they can be on oral levodopa with monitoring of the liver enzymes as well as the electrolytes and the creatinine. Because of the effect that the conditioning has had on the immune system, these patients need to be vaccinated post-transplant. The post-transplant vaccination starts with the influenza vaccine, which is given annually to them approximately about 6 months post-transplant, depending on the condition of the patient. Each country has its different vaccine schedules. We have our own. There are several live vaccines also which are given post-transplant. However, live vaccines are given only after 2 years post-transplant, and then the patient also needs to be off all immunosuppression. Certain vaccines like the oral polio vaccine is contraindicated post-transplant. There were a few things I forgot to mention about the donor. I would like to tell that at this point, a donor, a sibling or otherwise who is a thalassemia carrier is still a suitable donor. ABO incompatibility is not a contraindication. However, sometimes older patients less than about 40 years of age may not be used as donors, and a younger donor is preferred. Hematopoietic stem cell transplantation for patients with transfusion-dependent thalassemia is now happening at Lady Ridgeway Hospital as well. The first transplant was performed at LRH in December 2021. Our center also helped in initiating this transplant. Regular transplants from matched siblings, HLA matched siblings, are now happening at Lady Ridgeway Hospital. In addition, there are transplants for aplastic anemia as well as immunodeficiency happening. I hope I was able to give you an idea of how hematopoietic stem cell transplantation is offered to patients with transfusion-dependent thalassemia, and that you will be able to have an idea on how to optimize the management in preparation for the transplant program, as well as refer patients appropriately for transplants. Thank you.